Alrighty, good morning, everybody. For those in the room, apologies, the coffee is here now, so you can wake up. Welcome to our weekly medical grand rounds. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. Very important and timely grand rounds this morning. So my sincere gratitude to the organizers and to Dr. Stephanie Smith. So the title today is Update on Respiratory Viral Infections in Adults, Predictions, Vaccinations, and Treatments. So Stephanie's going to bring out her crystal ball. Stephanie needs no introduction, but of course, Dr. Smith is professor at the University of Alberta and Division of Infectious Disease. She's the current division director and section chief of ID in the Edmonton zone. She's director of infection prevention and control for the University of Alberta Hospital and the Mazikowski Heart Institute, and the medical director of IPAC in the Edmonton zone. And of course, many of us will remember that she was just a text or phone call away during those very difficult times during COVID. She's on a number of national and provincial guideline committees related to infection control practices to prevent the spread of antimicrobial resistant pathogens. She's a member of the PHAC Infection Prevention and Control Expert Working Group and co-chair of the Canadian Nosocomial Infection Surveillance Program. She's involved in medical education at the undergrad and postgrad levels and served as the program director for the ID training program at the University of Alberta Hospital for 9 years. And her research interests include the epidemiology and prevention of hospital-acquired infections, including those related to antimicrobial resistance. She also acts as site PI for a variety of clinical trials investigating optimal therapy for common infectious disease syndromes. So without further ado, I'll hand it over to Stephanie.
Great to be here, and I feel like it's been a few years since I've done this kind of talk. We're discussing that I might have a little bit of PTSD, but it's actually the timing of this is perfect in many ways. About 2 weeks ago, I wouldn't have actually had quite as much data as I do now to talk about kind of what we think is going to happen this respiratory season. So we'll get right into it. All right, so disclosures, as Dr. Kassan said, I am the co-chair of the Canadian Nosocomial Infection Surveillance Program. We conduct surveillance in a network of hospitals across all 10 provinces and territories. Some of the data that I'm going to present is from this network. I do not receive any remuneration from this, but just to let you know. And I don't have any other disclosures related to this talk. So a brief outline, we're going to talk about the epidemiology of respiratory viruses. I am going to focus on kind of the big three, so that's COVID, influenza, and RSV. We'll talk about kind of what's happened over the last year or so, and then what we think is happening now and what's going to happen this year. We'll talk a little bit about prevention, and that's primarily around vaccines, although we'll talk about some pharmacologic prevention tools as well. And then a little bit about therapeutics, and I'll kind of quickly go over the stuff that hasn't really changed a lot and just mention some newer tools that are coming down the pipeline. Okay, so let's get into the epidemiology. So this is just a graph from the last viral respiratory season. So this is Canadian data, and this is just percent of tests positive. And so you can see that, we had kind of an early peak of SARS-CoV-2, and then we had a later peak of RSV and influenza. And if you'll remember last year, we did have a very late peak of influenza. So it was really our peak ended up being in kind of late February, March, which was a bit unusual. But certainly we have seen sometimes late flu seasons in the past. And when you look at, again, so that was percent positivity. This is just the number of viral detections. Again, this is Canadian data. from last viral season, it looks essentially the same. So we have this kind of early peak of SARS-CoV-2, and then we had this huge peak of influenza, and a slightly earlier peak compared to influenza of RSV. And this is for all comers. And so certainly, I mean, we do see RSV causing disease in older adults, but this really probably is mostly children because it predominantly affects children and older adults. Okay, so let's look at hospitalizations. I think that's what, many of us are worried about when we think about viral respiratory infections. And so again, this is over a couple of seasons, but you can see, so the red line is SARS-CoV-2, the teal is influenza, and then the yellow, or orangey yellow, is RSV. And so you can see again, same pattern, right? With our hospitalizations, we had an earlier peak of SARS-CoV, then we had our influenza, and RSV tends to follow influenza or be a little bit before it. When we look at cases in Alberta, I think up until last viral respiratory season, we really saw a predominance of COVID. But this past season, we actually had more cases, just case numbers of flu compared to COVID. And when we look at the hospitalization rate, it was pretty much the same. So of the 14,000 flu cases, we had 25% hospitalization. Death still looks a little bit higher for COVID in the last respiratory season, but I do feel that there's probably some bias of attribution. We definitely test more for COVID still than we do for flu. And last respiratory season, there was still the ability to just test for COVID. Now we have the testing for COVID, RSV, flu. That's all together, but I think probably there was more testing and so more attribution. So what can we expect this year? So there's a number of different things we can look at, right? And one of them, of course, is what's happened in the Southern Hemisphere. They've just gone through their respiratory viral season, which tends to be in our summer months, their winter months. So this is data from Australia. Australia tends to have fairly good data in terms of especially influenza. So I focused on influenza here because I think this is the kind of area that's going to impact us predominantly in terms of hospitalization. So you can see the dark blue dotted line is what happened in their respiratory viral season just in the summer. So you can see not maybe as high a peak as it was last year, which is in the light blue, but it was a very prolonged influenza season, so much longer than normal. And again, this is a number of patients admitted. And so this is children and adults. They don't have it separated by age. But so you can see, quite a lot of RSV, and that would again be predominantly in children. But again, very little SARS-CoV-2 and quite a lot of flu and a fairly prolonged season. So what can we take from the Australian surveillance or Southern Hemisphere? Low rates of hospitalization with COVID, which is good news. And interestingly, the majority of hospitalized cases in their season were H1N1, although they do have a large proportion that were untyped. So they don't do quite as much typing as we have. There were increased cases of influenza B in children. And they did note, and I think this is important, and we'll talk quite a bit about this, is that they noticed increased cases of H3N2, which is a subtype of Influenza A, at the end of their respiratory season. And the thought is that that's what kind of caused that prolonged tail. So we can also look at typing from our viral respiratory season last year. And so this is a paper from Danuta Skoronsky, who is out of BC CDC. And so they actually typed 24,000 H3N2 sequences from the Northern Hemisphere viral respiratory season last year. And they noticed that there was a antigenic shift. And so there was a doubly mutated strain of the J2.3 and the J2.5. And so now that has become a new subclade of H3N2. Why do we care about that? We care about it because it does seem to be antigenically distinct from the 25-26 influenza vaccine for the H3N2 strain. So there's a bit of concern about the potential for increased cases or severity with the H3N2 strain, and I'll talk about that in a minute. It does tend to have higher mortality in older adults. And whereas H1N1 tends to have higher severity in younger adults. So in terms of H3N2 history, so, I think in most of our lifetimes, we've had circulating strains of H1N1 and H3N2. And so H3N2 actually emerged as a pathogen of concern with the 1968 pandemic, which people don't really think about because I think the 1918 was so much more severe, but certainly this was a severe pandemic. And since then, so since 1968, we've had H3N2 strains that are circulating as part of our seasonal influenza A. And the H3N2, some version of the H3N2 strains have been included in the vaccine. So the last H3N2 predominant influenza season was actually in 2017-18, so quite a while ago, but it had a much higher mortality, especially in older adults, of 10.8%. It does tend to undergo antigenic change in its hemagglutinin protein at a higher rate than H1N1. And so again, there's this concern that it can evade immune responses because there's not going to be as good a match with the vaccine. And again, it does tend to have a disproportionate impact on older adults, and that's thought to be due to some waning immunity, decreased response to vaccine, and lack of immunological imprinting. So what's happening now? And as I said, I think that the timing of this is really good because we've really just seen flu start to take off. So again, this is percent positive surveillance in Canada with SARS-CoV-2 in the blue. So you can see we had this kind of early peak that's coming down, very similar to last respiratory season. But in the last week or so, we've had this huge increase in influenza, and then a bit of an increase in RSV. And again, this is just number of viral detections, and it follows a very similar path. So we are now, looking at the last 3 viral respiratory seasons just for flu. You can see that, again, the red is from 23-24. The yellow is from 24-25, and we're in the blue here. So we've just crossed that kind of 5% positivity rate. So we're now in our true respiratory season, or at the epidemic threshold. And when we look at, what strains are circulating, this is really early data. We don't actually have a ton of data on the types yet, just because, again, the numbers are reasonably small. And I apologize that the colors of this are like terrible to distinguish. But so the pink is those that are untyped. So again, a large proportion, we don't actually know what type it is, but the very dark red is H1N1. So you can see that, initially it did look like H1N1 was predominating. And that was the case up until literally about 2 weeks ago. But now we've seen that H3N2 seems to be predominating. And so it's now about 55% of all cases compared to 3 weeks ago when it was more like 40% of all cases. When we look at cases in Alberta, again, it follows a very similar trend. So this is just number of cases, and you can see, again, this is a little easier the color scheme is a little easier. So H1N1 is in the dark pink, and H3N2 is in the blue. And so you can see again that we've had this, quite significant increase in H3N2 cases. And I put the COVID cases just for reference because up until literally the last 2 years, we've really seen way more COVID cases than we have influenza, even if we didn't have as many hospitalizations in the last year. But now you can see that, we're upwards of almost 400 cases of flu in a week, and here we're down at less than 150 COVID cases. And again, this is hospitalization in Alberta. So both ICU and non-ICU, you can't really even see the ICU numbers yet because it's too early and we haven't had a lot of them. But again, you're seeing basically this same trend that we're seeing an increase in hospitalizations. And again, this is for all flu. So I not distinguish between H3N2 and H1N1. Okay, so when we look at the antigenic components of the vaccine and whether or not it matches with what we're seeing circulating, we really don't have a huge number of cases that have been analyzed yet. Again, we're so early in the flu season, but we do have some. So for H1N1, there were 40, this is again Canadian data, there were 40 isolates that were analyzed. And all but one showed, there was only one, I guess, that showed reduced titer with anti-sera from the vaccine strain. So it does appear that there's a good match with H1N1. H3N2, again, this is the vaccine that's included in it. So A District of Columbia 27-2023. There were 38 viruses or isolates that were analyzed. 31 actually had reduced titer with anti-sera from the vaccine strain. So again, this is getting at that issue where we have subclade K that we are presuming is the clade that is actually circulating, and it doesn't mean that there's no protection from the vaccine, but there does appear to be reduced protection from the vaccine. And then influenza B, I think it's way too early. The Victoria lineage is what's included in the vaccine. There's only been 2 viruses analyzed, and both of them appear to be have reasonable titers with the vaccine strain. And again, this basically just shows the genetic characterization. And so again, focusing on the H3N2, the majority of cases that have been characterized are in this K clade. And again, that's the clade that is not included in the vaccine. So, I think in terms of epidemiology, it does appear that we are going to have an H3N2 predominant influenza season. It does appear that SARS-CoV-2 continues to decrease, and so with the increase in H3N2, then I think we can predict that there will be a significant impact on older adults, and we will see more hospitalizations related to that. I haven't talked too much about RSV. Certainly, RSV is also a concern in older adults, but again, when we look at hospitalizations, it's still predominantly in children. So let's talk about prevention a little bit, and this is kind of a mishmash. It's a lot about vaccines, but there's a few just kind of interesting tidbits as well. So we'll talk first about COVID vaccines. I think, when I first started giving these grand rounds, it was all about the variants and the vaccines and the match with the variants. And there hasn't really, you probably haven't heard that much about that recently. And that's really, the strains continue to evolve, but they're all kind of Omicron variants. So this is what's circulating now in Canada. And the vaccines do have a good match against all the XFG strains, as well as the NV and the KP3. So in terms of, matching the strains circulating, the COVID vaccine certainly is a good match. So in terms of recommendations, for who should get a COVID-19 vaccination, so these are the NACI guidelines, the National Advisory Committee on Immunization. And so it's recommended, obviously, for those who are at increased risk of SARS-CoV-2 infection or severe COVID-19 disease. And so obviously that's older adults, age 65 or older, and those 6 months or older that have increased risk. So long-term care with underlying comorbidities, and we'll talk about that a little bit, or pregnant women, individuals from First Nations, Métis, and Inuit communities, members of racialized or other equity-denied communities, or inner city populations certainly would fit in that category. and healthcare workers and other care providers and facilities. So this is, pretty broad, right? And then there's a statement saying all individuals 6 months of age or over not in the preceding list may receive one of the COVID vaccines. So again, it's not really saying they're not they're saying you may have it. And so we'll talk a little bit about why that is. Now in Alberta, we have not mirrored the NACI guidelines entirely. So healthcare workers are eligible for vaccine, residents of long-term care and supportive living, individuals experiencing homelessness, and individuals 65 and older with comorbidities, as well as teachers thrown in there with the legislation after the back to work rule. And then those at risk for severe disease. And so when we look at, this is small and I apologize, but when we look at the list of those who are at risk of severe disease, it's actually fairly comprehensive, I would say. So, everything from, the things that you would think about, chronic liver disease, lung disease, et cetera, but even things like, ADHD and depression are included in this list. So, when you look at the list, then you could say, well, sure, okay, most people that would be at risk for severe disease are included. And certainly I would say our public health officials have been very permissive. So I had a patient that went to the public health clinic and he is 65, but he has really not very many comorbidities at all, except for hypertension. And they said, oh, well, that's a cardiovascular disease, so we'll give you a free vaccine. So, I think that overall, certainly the recommendations are reasonably broad. But of course, as all of you know, access has been the major issue, and I think messaging as well has been the major issue. So primarily, at least initially in the immunization campaign, if you could call it a campaign, then public health clinics were the only place where you could get a vaccine. And then it evolved into, some pharmacies will provide it, but you have to pay up front, and then you can be reimbursed. And pharmacies are often charging more than the $100 that you would have to pay at a public health clinic if you're not covered. So there's a lot of confusion, a lot of mixed messaging, and really difficult access, I would say, because, especially for an older individual who's trying to navigate the online booking system, there's a lot of confusion. And so that's resulted, I think, in our pretty poor uptake of vaccines. So right now we're at about 5% of the population of Alberta that's been vaccinated. And of course, you miss 100% of the shots you don't take. So even if our vaccines are not perfect in terms of, we know that the COVID vaccines have fairly quickly waning immunity and not 100% protection, but certainly when we only have 5% of the population vaccinated, we can anticipate that we're going to continue to see hospitalizations related to COVID, even if they're not kind of in the epidemic curve that we are seeing with flu. So, the question is, I think a lot of people have questions about, well, do we still need it? So does your 18-year-old child need a COVID vaccine? They'll have to pay for it, and they'll have to be booked into a public health clinic, and there's a wait and all that kind of stuff. And so I think, it is a challenging issue, but I think that there's a couple of studies that were interesting, not so much in the 18-year-old child, but just, I think this will give you some reference. So, I think people have questioned the need for a yearly booster shot. And especially because the studies that we have, from early on in the pandemic are not really relevant necessarily or representative of the population we have now, where we have almost everyone's either been infected, had multiple vaccines, so they're going to have some partial immunity. So this study was published in the New England Journal of Medicine, and it looked at Veteran Affairs patients, and they looked at the 24-25 COVID vaccine. So they looked at 160,000 veterans. And I think the key here is that they actually compared those who got flu and COVID to those who got flu alone. And that's important because it removes that we all say, oh, if, people that are vaccinated are generally healthier, but these people were getting at least one vaccine. So they weren't complete anti-vaxxers or anything like that. They were either getting a flu shot or flu plus COVID. So again, 160,000 compared to 130,000 who received the flu shot alone. And then they were followed for 6 months to see if they developed COVID. And, of course, when you look at table 1 here, this is not necessarily representative of our whole population. It's mostly men, older, so average age is 71. And as I said, about 90% men, mostly white, about a third or almost 40% smokers. But I think, these are certainly people that are at risk for severe disease. I think we could all agree with that. And what they found was that there was a 29% lower risk of COVID-related emergency department visits, 39% lower risk of hospitalization, and 64% lower risk of death. So in this population, you could certainly say, this is probably a vaccine worthwhile getting. Now, I will say that these are relative risk reductions, right? So you have to take that into account. So it seems really dramatic, but it is relative risks. And so you can certainly calculate the number needed to vaccinate to avoid these outcomes. And so for emergency department visits, you would need to vaccinate 546. For COVID hospitalization, about 1,300. And to avoid one COVID-associated death, that'd be about 4,500. So again, you look at that and you think about the cost of COVID vaccines, it's still probably cost effective in this population. But, you think about that and then you think about like a 25-year-old totally healthy person, the number needed to treat would be incredibly high. And so, I think you have to look at kind of the risks and what your 25-year-old patient is, if they have comorbidities, but if they don't, are they interacting with people that have comorbidities? Maybe that would make you think that they should get vaccinated. But again, I don't think that you necessarily have to have a blanket statement saying COVID vaccination for everyone. Okay, so what about non-vaccine prevention? So I'll just go through a few kind of interesting tidbits. So there's a new antiviral, a protease inhibitor called ensitrelvir, and it was initially tested as treatment for COVID-19. But there's a new study called Scorpio PEP that actually, it's a phase 3 RCT, and it compared ensitrelvir to placebo for household contacts of COVID-19. So essentially giving it to people who had a household member that had COVID. And it showed a 67% reduction in COVID-19 infection in household members at day 10 post-exposure. And so it's currently being evaluated for FDA approval for that indication. Certainly you could say, well, it's a niche market, like who's really going to pay for their household members to take this medication to prevent COVID. But I think that, there may be certain high risk situations, but to me, I would say in the hospital setting would be potentially a place where we would consider using this because if we have a patient that tests positive for COVID in our hospital and they're in a semi-private room and there's an OCP patient in there, then the risk of those two roommates actually getting infected is reasonably high. And having some kind of pharmacologic prevention, I think, would be welcome. So more to come on that. It's not available in Canada. So again, when we look at, how can we prevent hospital-acquired viral respiratory infections, and again, this is on the prevention side. This was a study that we did through CNISP, and we basically looked at all of our hospital-acquired viral respiratory infections. And so this isn't just COVID, it's flu and RSV, but it's predominantly COVID cases. And so we looked at 79 hospitals across Canada, both peds and adult. We compared rates of flu, COVID, and RSV. And then we tried to correlate it with hospital characteristics. So things like use of universal masking, proportion of single patient rooms, HVAC characteristics, healthcare worker testing on site, although that's not really a thing so much anymore. And what we found in terms of univariate analysis is pediatric hospitals are protective. So certainly way fewer hospital-acquired cases of viral respiratory infection in peds. And this is predominantly because there's way fewer cases of COVID. And COVID does tend to be the predominant hospital-acquired virus. Interestingly, teaching hospitals were also protective. Why that is, I don't actually have a really good explanation. We've kind of tried to hypothesize, but it's a bit unclear. And then the only other thing that was significant in our univariate was proportion of single rooms, which I think is not entirely surprising. Universal masking was not actually effective, interestingly. And when we did multivariable analysis, the same kinds of things came out. So pediatric hospitals, and again, if we took COVID out, then it actually completely erased that difference. But proportion of single bed rooms. So for every 10% increase in the number of single rooms you have a 12% decrease in viral transmission. And then again, teaching hospitals still came out as being protective. But again, masking did not. And so I think, that these are correlations. It's not necessarily causation, but just some interesting data. On a slightly different note, this got a lot of press in, I think, the kind of fall about how SARS-CoV-2 vaccines tend to sensitize tumors to immune checkpoint inhibitors. This was published in Nature. And it's, I think it's super interesting and hypothesis generating. I don't think it means that, this is going to help cure cancer for sure. But essentially the hypothesis is that mRNA vaccines targeting SARS-CoV-2 actually sensitize tumor cells to immune checkpoint inhibitors. And so they looked at patients with non-small cell lung cancer and melanoma. And so the red is those having no vaccine. The blue is those having COVID vaccine. And you can see the survival is increased in basically all of these different, and these are different stages of cancer. So I think kind of interesting. Maybe it will convince some people to get vaccinated for this reason, even if they don't, they're not worried about COVID. Okay, so we'll move on to flu vaccines. So again, lots of different vaccine formulations available in Canada. We have 11 different vaccines that are authorized, 9 are inactivated, 2 adjuvanted, 1 high dose, and 6 standard dose. We have a recombinant influenza vaccination and then a live attenuated influenza vaccine, which is FluMist. And we've now transitioned from having quadrivalent vaccines to trivalent. And why is that? We continue to still have 2 strains of influenza A, so H1N1 and H3N2, which we talked a little bit about. There traditionally have been 2 strains of influenza B, so the Victoria and the Yamagata lineages, but since 2020, we've had no cases of Yamagata circulating, and so now the WHO has recommended that be removed from the vaccine. So we've gone from quadrivalent back to trivalent. So in terms of recommendations, I think this is kind of a busy table. Flu vaccine is really recommended for everyone. But in terms of the formulations, the main thing is those that are older, the adjuvant, especially those who are 65 years and older, the adjuvanted or the high dose are recommended over the standard dose for increasing response to vaccine. When we look at efficacy of flu vaccines, so, I think flu vaccines get a bad rap, in terms of, well, they're not very effective. But overall, when you look at it, they're about 40 to 45% effective in preventing disease at all. And influenza is kind of miserable. So still, I think I would take this shot. I have taken the shot to at least give me that protection. And then again, 45 to 50% effective in preventing hospitalization. And this is based on data from the last viral respiratory season. Now, we are expecting a potential decrease in efficacy due to the mismatch with the H3N2 strain. But I think that, again, I don't want to be, I think we still do get some protection. So it's not completely ineffective. And again, this is the data that we have. This was, again, a study published in the New England Journal, and it just gave updated evidence around vaccine efficacy from the last viral respiratory season. This is for flu. This is just for influenza. So you can see, again, for all comers, so all adults, about 43% efficacy, for younger adults, 48%. And then I apologize, that got cut off, but for older adults, about 43%. So still, I think well worth getting, especially if you're at increased risk for severe disease. So what's our current vaccine uptake in Alberta right now? 17%. So again, you miss 100% of the shots that you don't take. So I think, and I think again, we can say, well, a population is vaccine hesitant or anti-vax, but I think it's also a lot of confusion and a lot of, lack of clarity in terms of messaging. And I think because there was so much confusion with the COVID vaccine and how it rolled out and how you were to get it, I think there was also, even though the way that we're delivering flu vaccines is the same as we have in the past, I think there's still a lot of confusion about how you can get it. So people can get it at pharmacies, public health clinics, et cetera. It is free, but I think that messaging just really hasn't been clear. Okay, so let's talk briefly about RSV vaccines. So we have, again, RSV certainly causes severe lower respiratory tract infections in older adults with high morbidity and mortality. There's 3 different approved RSV vaccines in this population, and they use different types of technologies, protein subunit or mRNA. And they're recommended for adults age 60 with expanded eligibility for high-risk individuals and pregnant women between 32 and 36 weeks. And again, that's to protect babies from RSV, who we know tend to bear the burden of more severe disease. In terms of in Alberta, right now, RSV vaccines are, patients are eligible for RSV vaccines if they're community dwelling 70 years and older, Indigenous individuals, or residents of facilities. So pretty narrow, and everyone else has to pay for it, which is a problem. When we look at the efficacy, it's really quite impressive, I think. So again, these are the 3 different vaccines that we have. With the Abrysvo, it's about 88.9% effective in against lower respiratory tract infection for season 1, and it actually does extend 2 seasons. So basically, your initial vaccine will cover you even into the 2nd season with about 77.8% efficacy. For the mRNA vaccine, again, for a single season, 83% effective at preventing lower respiratory infection and 64% at preventing acute respiratory disease. And again, that's just single season. And then Arexvy, again, this looked at hospitalization, not lower respiratory tract infection, and about 60 to 65% reduction in hospitalization over 1 season. So these are vaccines that are actually very effective in a population that's, certainly for older adults who have a high risk for severe disease. Okay, let's talk about therapies. So I would say for COVID, nothing has really changed a whole lot, but there's a couple of things that I think is important to think about. So for antivirals, we still have, the same antivirals that we've used in the past couple of years, remdesivir and nirmatrelvir and ritonavir, so Paxlovid. I think, we tend to kind of default to using remdesivir in hospital. I would say that lots of patients do not necessarily qualify for remdesivir in hospital. It's, only if they have more severe disease. So if they're hospitalized for their COVID, then that's, a situation where you may want to give remdesivir. But if they happen to test positive for COVID, either on admission or during hospital, but they're hospitalized for something else and they have mild disease, but you're worried that they're maybe at risk for more severe disease, then Paxlovid would be an option. I think the challenge, of course, with Paxlovid is that there are a number of drug interactions, and that's what probably limits our use a little bit more in hospital. But certainly, I would encourage you to think about kind of Paxlovid first in your patients that have more mild disease and are being admitted with something else. And then our immune modulators, so tocilizumab is still certainly should be considered in those with severe disease. And I think, we don't tend to see as many patients with COVID with severe disease that are on more than 8 liters of oxygen or that kind of thing. But in those patients, certainly this should be our first line agent. And then, of course, corticosteroids for severe or critical illness. So in terms of, as I said, with Paxlovid, the challenge, of course, is that the ritonavir portion is the problematic portion. So it inhibits the CYP3A4 as well as the CYP2D6. And so again, and then there are enzyme inducers that can reduce Paxlovid levels. So it is, something to keep in mind. So things like certain statins, amiodarone, sildenafil, and midazolam are all absolutely contraindicated with Paxlovid, and then there's a longer list of relative contraindications. So, there's a number of newer medications in the pipeline looking at, trying to block viral replication with reduced drug interactions and resistance risks. There's broad spectrum antivirals that have activity against all coronaviruses. And then certain monoclonal antibodies that, again, try to target the conserved region of the spike proteins. And so, again, would have more durable protection against all different strains of SARS-CoV-2. And then there's a couple of Pemgarda is a long-acting monoclonal antibody. And again, that would basically, act to protect someone over a viral season. And then for influenza therapies, they're really pretty limited. I'll be honest, there's not a whole lot that's new. I do, certainly oseltamivir should be considered in anyone that is hospitalized with influenza. The risk reduction for hospitalization with oseltamivir is 37%. Even if they're sick and they're coming into hospital, it should absolutely be considered. In the outpatient setting for mild disease, it kind of decreases symptoms by about 24 hours, so not super impressive. Zanamivir is not something we generally use. It's an inhaled formulation. And then peramivir is an IV formulation. And these are available through SAP only, and baloxavir is an oral one-dose medication. And I'll talk about kind of the challenges with some of these. So, of course, starting early is the key here. You really need to start when there's active viral replication in order to have the best efficacy of these medications. They should certainly be considered in high-risk groups, so elderly, young children, pregnant women, and those with chronic conditions. The side effects, oseltamivir, certainly nausea, vomiting is the most common, but still reasonably well tolerated. Zanamivir cannot be used with anyone with underlying respiratory conditions, which really limits it because, of course, that's the patient population you're probably going to want to give it to. It does cause bronchospasm, and so we really don't use it at all. Peramivir, again, is available, it would be available if it's an IV option. So again, if you have someone that's critically ill in the ICU and you need to give them something IV, then you can get this through SAP. but it does cause, there's issues with diarrhea and rare skin reactions. And then baloxavir, again, is generally well tolerated. It's one dose, so it sounds like it's a good option. But there's been, even in the early phase 3 trials, resistance has developed. So this, again, is not used as commonly. And so, even though, it seems like we haven't had any new influenza options for quite a while, there are a few things that are in the pipeline, including, monoclonal antibodies, as well as some different polymerase complex inhibitors and proton channel inhibitors. So I think, but these are all in very early stages of study. Okay, so what about RSV? And again, I haven't focused on the approved drugs for children as much, which would be nirsevimab and palivizumab. Palivizumab has been around for a while. It's a monthly intramuscular injection that's given to high-risk infants, so premature congenital heart disease and chronic lung disease. To prevent RSV, and nirsevimab is a long-acting antibody given as a single IM injection to protect infants during the RSV season. So we've now really moved to using nirsevimab over palivizumab because of its ease of administration. But these are only used right now for prevention in infants and children. And then in adults, there's really not a whole lot. Ritonavir has been used in certain settings, but the efficacy is fairly minimal. There's a polymerase inhibitor that's again in phase 2 trials, and a fusion inhibitor that's just in early trials. So, I think there's some interesting things that are coming down the pipeline, but we'll be a little ways off. Okay, so I think that we've got time. We've got some extra time, so we'll have some questions, and then Norman has a few things to say. But I think the summary here, COVID-19 certainly is now part of the seasonal viral respiratory landscape, similar in severity to flu for those who have comorbidities. We are bracing for a potentially severe influenza season because of the predominance of N3, H3N2, Influenza A, and the vaccine mismatch. And vaccination for COVID, influenza, and RSV is still probably our best protection in terms of preventing severe disease. And then we do have some treatment options for those that are at high risk for severe disease, but they really need to be started early in the course. And so for those of you who are admitting patients, and they have any of these, that's the time to start treatment. All right, stop there.
Thanks for sharing your crystal ball with us.
Well, I'm not going to crystal ball now because
there's a lot of questions online, but I was going to give people in the room a chance first. So the first one is from Lenora. She said last year apparently there was a double hump or different dominant of influenza peaks between Calgary and Edmonton. And so do you think this pattern, that patterns are becoming more predictable as a result of that? And then she also asks about the fact that, people, the general lay public gets wind of the influenza vaccines not being effective. And so what is the messaging? We kind of covered it.
Yeah, I think that there definitely are, when you look, drill down into influenza epidemiology between provinces and even between cities, there's slight differences. But when you look at, when you kind of combine all the data together, then you get still the same general pattern. It's interesting that we always have way more COVID than Calgary for reasons that are not entirely clear. Vaccination rates aren't really all that different and that kind of thing. So there's always going to be a little bit of variability. But again, I don't think that that really affects what our recommendations are going to be. And, I think the messaging, even though I've gone through, the concern that we have about slightly decreased vaccine efficacy, still absolutely it's going to provide the best protection, and we still should be recommending it for all of our patients, and especially those at high risk.
Do you think that this year, I mean, we're now end of November, our first snowfall finally. Are you thinking like last year we had a later peak, but like we're probably going to go into January, February?
Yes, I mean, I think, I guess it's hard to entirely predict, but doing, in the last 2 weeks, we've really started to see that spike. I mean, we had, from August until now, in Canada, we've had 4,000 cases of influenza, and 1,400 of them have been in the last week. So, that gives you a sense of like, we're on the upward peak. I think that, whereas last season we had our peak in late February, but I think it's pretty clear that we're going to have a more typical peak this season
Based on Australia.
Yeah.
Okay. Hayward is just wondering if those preventive measures that were looked at, I mean, the single room really resonates with those of us that look after inpatients.
Yes.
But any word on hallway and overcapacity room? I think you talked about overcapacity, but the hallway beds and that having an impact on.
Yeah, I mean, I don't have any data, but I would say absolutely, when we look at our outbreaks, we definitely see more transmission in scenarios where you have OCP stretchers between two patients. So there's definitely more transmission that goes on there. We have certainly had hallway patients that have ended up testing positive for COVID or flu during their hospitalization, and that have triggered outbreaks. So, there's absolutely risk to all of this. It's certainly not my preference to have OCP stretchers or hallway beds. I think it's, it is a challenge. I mean, if you talk to administration, they say, well, or, and they say this to me because I say, no, we can't have hallway beds and we can't have OCP beds, but they say, well, do you want someone to die in the waiting room because there's such a backlog and they can't get in and those kinds of things. So it's, we're kind of weighing risks and benefits in a really terrible situation.
It's the reality, or they're sitting languishing in the emergency department. It's true. Thanks for this great update. I'm curious about the vaccine uptake rate. You mentioned flu vaccine right now is about 17%. How does this compare to pre-pandemic? Wondering if COVID pandemic has caused a vaccine fatigue that is now bleeding into other vaccines.
Yes. Yeah, I mean, we traditionally pre-pandemic, we usually had vaccine uptake. I mean, it wasn't great, but it was around kind of 35%. And there's still obviously time and some of our data is a little bit behind. So like, am I up to date today? No, this is data from about a week to 2 weeks ago. I think that there still will be a little bit of an increase, but absolutely we have certainly fatigue would be the nice way to put it. I think that, there's a lot of hesitancy. There's a lot of just general, feeling of vaccine, like, I guess, lack of confidence with healthcare providers and that kind of thing post-pandemic. So I think there are a lot of challenges, but I think also there's a lot of unclear messaging and that has not been helpful in terms of getting our vaccine uptake.
And difficulties with booking and
like access. I mean, I certainly will not put it all on the patients. It's also the fact that it's just been incredibly difficult to navigate how to get your vaccines this year, especially with COVID.
Okay, so Nancy says that APL won't do NP swabs for viruses. What is the best way to test high-risk patients with symptoms who would benefit from treatment if they're positive as outpatients?
So, I mean, she's right that like APL won't go into people's homes generally and do it. So you would have to like bring them in to get tested.
So that it's not an issue if you send them to a lab. They
won't do an NP swab for so it is an issue in terms of getting tested. And you would have to bring someone in to do a swab. And again, I mean, the main thing, I don't think you need to do RPP in everyone, and that, because APL does not want you doing RPPs in the outpatient setting. It's not actually going to change your management for anything besides COVID, flu, and well, basically COVID and flu, really. So that's what you should, like, we have the rapid COVID flu RSV test, and that's what we should be doing in outpatients or in emergency patients that aren't going to be admitted. The only reason really to do RPP, obviously in the inpatient setting, we want to know if they have a viral respiratory infection, isolate them. And it also may help to kind of sort out the diagnosis a little bit. So, you know, if you think, well, I don't know if this person has a viral pneumonia or bacterial pneumonia, but they end up testing positive for adenovirus or something like that, then it can help to reduce, you know, your antibiotic use, that kind of thing.
So Vanessa says apparently there's an anti-cancer benefit with HPV vaccines.
Yes,
good to know.
Exactly. It all comes back to viruses, right? So vaccines can help.
And Brian Rowe is asking about the availability of Paxlovid generally.
Yeah, and that's a good question. And you know, Brian, you're right that some pharmacies don't carry Paxlovid. They would have to bring it in. It should, and I think probably, you know, there is more stock in pharmacies now during the viral respiratory season, but pharmacies should be able to bring it in if they if it's ordered. But yes, without a drug plan, it is costly, and that is a challenge. And I don't have a good solution for that.
Isabel was asking about RSV, that table that you put up. So is a booster recommended for RSV on an annual basis?
So right now, as I said, we have data kind of out to 2 years. And so right now the recommendation would be every 2 years, but I think we'll get more data as time goes on in terms of how long the durability of those vaccines is. So yes, people would need boosters.
Dina.
Yeah.
Two questions that are related. Vaccination rate healthcare worker, is it also less this year? Like, is there, like, in your study or other data where you showed that healthcare vaccination decreases hospital accession?
So that is something that we're going to be looking at is healthcare worker vaccination. Unfortunately, that data point is difficult to get for some hospitals, and that's why we don't have it in that study. We have an easier time getting healthcare worker vaccination at our sites than others, interestingly. But interestingly, healthcare worker vaccination rates this year are actually higher than they've been in the last couple of years. And so I don't know exactly what the reason is, but somehow I think if you make it more difficult to get, people want it more or something. And so we actually we have had and I don't have the final kind of percentages yet from WHS, but they have said that their preliminary data would suggest that they actually have a higher vaccine uptake this year compared to previous.
I mean, I personally felt it was so easy for healthcare workers this year, and there were no lineups. We didn't have to chase down the flu cards, and you could do both at the same time.
But I think the fact that you couldn't get it, like you couldn't get COVID anywhere else, and so you had to get it here. Somehow people were like, okay, well then, no, I want to get it because I can't get it anywhere else. I don't know what the reason is, but yes, healthcare workers have stepped up, and their vaccine rates are actually a little better.
So the last question I think would be really good for us to end on is, you know, what do you, as an expert, Steph, what do you recommend in terms of preventive measures for all of us? You know, we go to conferences, we go on vacation. The masks were a little bit disappointing in terms of a preventative measure for healthcare workers or for hospital outbreaks. What is your overall recommendation in terms of prevention besides the vaccines, obviously?
Yeah, I mean, I think that, we're at a point now where we're in society. I mean, I don't mask. I don't really think that it's absolutely necessary. If you're an otherwise healthy person, you're not at risk for severe disease, you've been vaccinated. Do you really need to be masking in the community? Probably not. What I would really love, and I think that it would help, it would fix a lot of our problems, is if anyone has respiratory symptoms, if they masked wherever they went for that, because the reality is that you have a sniffle, you have kind of a cold, And people don't mask, right? And they go out and about in their day. And if the people that are ill could just mask, that would make a huge difference. And then I think in our hospital setting too, it's really hard to tease out if someone gets COVID, like a patient gets COVID because of a healthcare worker or because of another patient. But again, our healthcare workers should mask if they have a sniffle. If they feel okay and they're coming to work, but, oh, I've got a bit of a scratchy throat, mask, please. I think that will go a longer way than just saying everyone mask all the time. I think there's certainly, a lot of concern about our planetary health and about infection control practices and the widespread use of disposable masks and that kind of thing. So we really need to think about, using them in an appropriate way, and absolutely masking if you have any hint of illness, I think is a good idea. We do recommend masking if we have an outbreak ward, but right now there's not really. I think there's not enough data and there's not enough transmission going on in the hospital that we're going to recommend universal masking.
Thank you. That's really helpful. And, certainly when we go to meetings and see people coughing and you want to hand over the mask, but
Yes.
yeah, we'll need to do more messaging. So on behalf of the department, I wanted to thank you. That was very timely and very apropos. But I just wanted to take a minute to acknowledge and recognize that this was a very difficult week for our program directors. It was very challenging. It's obviously not the week. It's been the work that's been led up to the week. So it was accreditation week for all our residency programs. We have 16 residency programs and a number of AFCs that were reviewed, and there was so much work that went into it. So I just want to take this opportunity, first of all, to first and foremost acknowledge the program directors for all of their hard work, and thank the residents and the faculty and the administrative staff for participating in this really important endeavor. And obviously more information to come, but for the most part, I think we did pretty well. So I'm pretty happy about the outcomes. So congratulations to the program directors. Thanks. Have a wonderful weekend, everybody.